Diagnosis. The accurate diagnosis of stone in the kidney, pelvis, or the ureter must cover the following points. 1. The presence or absence of stone. 2. The number, position, and distribution of stones. 3. The presence or absence of renal infection. 4. The functional capacity of both kidneys. In order to make this diagnosis, familiarity with radiography and with the methods of testing the renal function is essential. Without the X-ray and the ureter catheter, it is possible in certain cases to diagnose the presence of stone with some accuracy and to operate for its relief with some success. But both methods are necessary in order to ensure good work in all cases and in order to ensure any diagnosis at all in some. The most typical history of renal stone, even if accompanied by characteristic gross evidences of such conditions as pyelonephrosis or calculus anuria, is not enough to indicate to the surgeon such important facts as the position and number of the stones present or the functional capacity of the opposite kidney. And most cases first apply for relief at a time when the history is anything but characteristic, the physical signs anything but adequate to ensure appropriate treatment. The following table, which has been prepared by Dr. Charles Eastman as a result of his radiographic experiences, indicates quite accurately how often the symptoms and physical signs are misleading as to the presence or absence of stone. They are still more often misleading as to the condition of the kidneys. Total cases, 80. Calculus present, 23, equals 28.75%. Negative, 57, equals 71.25%. 23 cases of calculi with typical symptoms, renal, 8. 2 had additional calculi in opposite kidney. With indefinite symptoms, 9. With symptoms on opposite side to calculus, 3. With symptoms referred to other parts, 3. Of these, 2 had renal symptoms with calculi in the bladder, 1 vesicle symptoms with calculus in kidney. 58 with typical symptoms, calculi, 14 equals 24.14%, calculi in suspected region, 8 equals 13.79%. 22 with indefinite symptoms, calculi, 9 equals 40.90%. Urine, 23 with calculus, 57 negative. See table. Our means of diagnosis may be summed up under the following heads in the order of their employment. 1. The patient's history. 2. Physical examination and urinalysis. 3. Radiography. 4. Substitutes for radiography. 5. Ureteral catheterism. 6. Exploratory operation. Patient's history. The presence of calculus is suggested by history of the passage of stone, of renal colic, of anuria, or by the presence or history of stone in the bladder. Every case of pyelonephritis is suspected to be calculus until the absence of calculus has been proven by radiography. Yet how misleading the history may be is shown by the table given above. Physical examination and urinalysis. The presence of stone in the bladder or of renal infection suggests the possibility of renal or ureteral stone. It is exceptionally possible to palpate through the vagina or the rectum large stones incarcerated at the lower end of the ureter. Urinalysis suggests stone when crystals of uric acid or oxalate of lime are present in great numbers, especially if these are found in the rounded forms. A relatively high percentage of urea in relation to the urinary specific gravity is suggestive of stone, and the presence of blood cells with crystals in the urine is peculiarly suggestive. Yet the passage of crystals alone often causes renal colic and may even produce a macroscopic hemorrhage. Moreover, while the rule is almost universal that so long as stone is present in the upper urinary tract, there are constantly a few blood cells in the urine, I have known 2 notable exceptions to this rule, i.e., 2 cases in which stone was present, but the urine showed no red blood cells. On the other hand, microscopic traces of blood are constantly found in the urine as a result of so many conditions other than renal stone that the presence of blood cells alone is no more than suggestive. Appendicitis and ureter stone give symptoms so closely simulating each other that special signs, notably blood and pus in the urine, have been sought to distinguish them. But appendicitis can cause hematuria through involvement of the lower ureter in the inflammation, or by causing toxic or bacterial nephritis. The presence of tubercle bacilli in the urine does not exclude stone, for secondary stone may form in a tuberculous kidney. Radiography. A good radiograph is the surest evidence in the diagnosis of renal and ureteral stone, figures 30 to 35, plates 3 to 8, for it shows the size, shape, and disposition of calculi. But an X-ray plate is by no means infallible. It may fail to show a stone, even though the plate be perfect, and it may show shadows suggestive of stone when no stone is actually present. Real familiarity with radiography is required for the interpretation of plates. A few of the elementary requisites are detailed in Chapter 9, but this real familiarity can only be gained by long experience. The greatest check on the accuracy of radiography is to be sought in the evidence of renal insufficiency and infection, which always results from the presence of large stones, and the wax-tipped catheter, which confirms the presence of small ones.